we had done part one of headaches, and the part two is basically clinical scenarios. But just for a quick refresher, I'll recapitulate some of the information we shared last time. We said headache is very common in children. About 60% of children experience headache at some stage in their life. 20% of the children can have recurrent headaches, and about 1.5 to 2% can have chronic daily headaches. We know that less than 12 years of age, there is no gender difference, but after that, girls or females outnumber boys or men. We know that there are primarily two causes, groups of causes of headaches, primary and secondary. It's important to be aware of secondary causes because from our history examination, we try level best to ascertain if we are not dealing with a secondary cause, because management in that case can be different. So we have to be aware of that. Okay, so we know that primary headaches are a long list, but we want to be sure about at least three causes: migraine, tension type headaches, and trigeminal autonomic cephalalgias, primarily cluster headaches. Secondary, we know there can be intracranial causes and extracranial causes. Of particular interest are intracranial infections, idiopathic intracranial hypertension, hydrocephalus, space occupying lesions, and Chiari malformation. Now, one still in this group I have highlighted is medication overuse headache, very common and generally overlooked, and very important to know about it for the purpose of management. Now, as I mentioned earlier, our primary aim is to differentiate between primary and secondary causes, and one of the ways to use is basically looking at the patterns. Acute headaches, you can see the graphical and pictorial representation: acute recurrent headaches, chronic progressive headaches, and chronic non-progressive. Dwell on this a lot here because we'll start with the cases straight away. Right. This is one of our cases here at a lady. 15 years. Ideally, a clinical scenario should be effective, given the limitations of our setting. So I'll do the presentation. Wherever I ask questions, you can whisper to yourself the answers and later on tally it with the answer. This is the only way, otherwise we cannot have interactive session here. So 15-year-old girl, this is just a few months back, presented to ED, not here, but in the hospital, with 6-week history of headaches. Every other day, headaches were occurring every other day, which would occur at night, were right periorbital in location, would last for about 60 minutes, were severe in intensity, continuous and deep, excruciating in character. Headaches were associated with swelling of the right eyelid, which I'll show you, and redness of the eye with watering. During the headaches, she would be restless. This is a very important feature that this type of headache patients, they generally are restless, agitated during the headaches rather than tending to be still and lie down as in migraines. This is opposite of that. There was preceding history of her head hitting ground. Actually, she was sitting on a chair and chair tumbled and she hit her head. And a few days later, she started having this. There was no associated nausea, vomiting, or phonophobia, but she did have some sensitivity to light. Now, the next line is you will understand, because we are trying to practice here that how to develop approach to headache. So no intermittent visual obscurations, pulsatile tinnitus and diplopia on lateral gaze, or any high pressure headache feature, which is basically coughing, straining and bending forward, and headache worsens. These are basically with reference to IIH or any space occupying lesion. There was no loss of consciousness or any focal deficit. In the ED, she had a CT scan, which was unremarkable. She had an ophthalmology review because she had a redness and swelling of the right eyelid. And this assessment was inconclusive. She was advised to attend an ophthalmology clinic in 2 weeks, and she was discharged with some analgesia. So when we saw her, so questions are basically, what is the headache pattern? So if you look at, because I'll be discussing from my side, if you look at this headache pattern, this is basically every other day she is having a headache, okay? And she had a preceding trivial trauma, okay? So, and duration is only, say, 6 weeks. So two groups can be used here. One is that it is an acute presentation. Okay, that's it. And then we know that it is a recurrent pattern. Okay, but there is a confounder here, which is actually a trivial trauma. So headache pattern, you can use either the acute one as well as the episodic one or recurrent one. Now, when we use the primary one, it includes both primary and secondary headaches. Acute can be like in meningitis and all those things. And even recurrent headaches, which are actually primary headaches, they can initially present as this acute presentation. Are there any red flags in this presentation? Yes, trauma is a red flag. Short duration of the headache is a red flag. Okay. Okay. All right. So, so that means headache pattern is basically, I've mentioned already, red flags. Trauma is a red flag. We see here that short duration, as I mentioned, these are red flags. Now, looking at, is it a primary or a secondary cause? Now, again, a difficult situation. It is a primary in a setting of trauma also. So when you will be classifying it, you have to think about these two things. What are the investigations we can do? In any child with headaches, the set of investigations which include fundoscopy for that purpose is an investigation here, and then neuroimaging can be an investigation here. And then in this case, actually, CT scan has already been done. There was no bleed or space occupying lesion. However, as we are aware, CT scan is not good at looking at the posterior cranial fossa. So MRI was actually planned by the hospital for this child. Till we saw this girl, the MRI had not been done, but she had not deteriorated, although she still had headaches. So these are the photographs of that child. So she has eyelid swelling here, and there is a conjunctival injection also. She actually has a cluster headache. Cluster headache is a primary headache. As we know, it is one of the trigeminal cephalalgias, autonomic cephalalgias, and we know the features to recognize. So basically what I want to develop from here, these clinical scenarios, is an approach. So always ask yourself which pattern of headache it is. Are there any red flags? And is it a primary or secondary? And accordingly, you can start treatment. Next is case number 2. This is an 8-year-old girl presented to our clinic with 2 years history of okay, 2 years history of episodes of headaches. Initially, the headaches were occurring at a frequency of once every month. However, for the last 4 months, the headaches are occurring 2 to 3 times a week. The headaches are bifrontally located, and they are 6 to 7 out of 10 severity, pulsating in character, can be associated with nausea. During the episodes, she is sensitive to noise and bright light. Most of her headaches are triggered by noise at school. Sleep helps ease her headaches. Family history is remarkable for headaches on mother's side, which are most probably migraine headaches. There are no nocturnal or early morning headaches. These are actually red flags I'm trying to ask here. There is no intermittent visual obscurations, pulsatile tinnitus, or diplopia. This is in relation to IIH or any raised intracranial pressure situation. And there were no features of high pressure headache, which as I mentioned earlier, headache worsening on coughing, bending forward, or straining. She sleeps at around 9 p.m. and wakes up at 7. So that means 3 plus 7, 10 hours, sufficient for her age. She drinks about 1.5 liter of water daily. Her meals are regular, and her screen time is 4 hours, which is a little more. As I mentioned last time, according to American Academy of Pediatrics, in older children, it should not be more than 2 hours, although none of us adheres to that. Okay, so her examination, including fundoscopy, as I mentioned, fundoscopy is an investigation here that was unremarkable. So what is the pattern? Pattern is recurrent headaches, but what we see here is that initially the headaches were infrequent and subsequently they became frequent. and frequent are, if we add 2 to 3 times into 4, so that will be 8 to 12. So that means they are still less than 15 headaches a month. So first we have to decide what pattern does it fit into, recurrent headaches. Are there any red flags? Overall, no significant red flags here. Is it pattern we have recognized it is recurrent? Initially, it was less frequent, so infrequent. Subsequently, it has become frequent. And so red flags are other. So it's a primary headache, and features are suggestive of migraine headaches. And there was no aura in this case. This is one of our real cases. So pattern is recurrent, red flags, none. Primary headache, yes. What is the investigation? Investigation in such cases, although generally in private setup, we have a low threshold of doing MRIs, and even parental pressure is always there. But we have to always weigh between the benefits and the risks. Although a migraine will be in a child generally at least older than 5, where you don't need general anesthetic. However, when general anesthetic comes into consideration, be very watchful. We should have a strict criteria met, that whether we are requesting the MRI and it is strongly indicated on. And then primary, so investigation, as I told you, you can do any bloods which are related here, but neuroimaging is not warranted as a first investigation. Very important. And management, if you remember the previous presentation, I had mentioned about lifestyle advice, which includes 5 things. It has to be adequate hydration, meal regularity, good sleep hygiene, minimal screen time, and engaging in physical activity. So we should start with that. We should ask them to maintain a headache diary. And analgesia advice should be ibuprofen is preferable over paracetamol. And depending upon the need, triptans can be used. However, one advice which should be explained and also documented in the paper, that generally the analgesics should not be used for more than 10 days in a month, because these can lead to medication overuse headaches. It's very important to document and counsel in the beginning. Case number 3, sorry for my fast pace. I'll try to slow down. Actually, I'm a natural fast speaker, but it may be difficult to follow. So I'll try to slow down. So a 14-year-old girl presented to ED with the history of progressively worsening headache, intermittent visual obscurations, pulsatile tinnitus, some people call it whooshing sounds in the head, and intermittent diplopia on lateral gaze over a period of 3 months. This is again one of my cases when I was at Liverpool. So past medical history, she has a polycystic ovarian disease, and she was treated with hormones. Her BMI was high, and headaches would worsen on coughing, straining, and bending forward. Now, so if doing that exercise again and again will help you devise your own approach. So ask, what is the pattern? So pattern is a progressive, chronic progressive pattern. And chronic progressive pattern is generally a secondary cause unless proven otherwise. Okay, so we are dealing with a progressive pattern. And what are the red flags here? Generally, less than 6 months duration of headaches is a red flag. Progressive pattern itself is a red flag. Worsening, progressively worsening headache is a red flag. Intermittent visual obscurations, pulse patch, these are all red flags. So that means we are dealing most likely with a secondary a cause here. And then, so we can conclude from that. And why is that important? Because it's very, very important to help devise the management strategy. What would you do in this case? So here, what you want to do is, when we check in the outpatients or in the ED fundoscopy, that is undilated fundoscopy. It's not highly reliable. The first attempt should be to confirm our undilated fundoscopy findings by requesting an ophthalmologist for a dilated fundoscopy. If the findings are confirmed, we always request them to, I'll show you that one, to do Frisson grading, because that is very, very important if it is IIH, because that will help you decide whether you have to arrange more frequent follow-ups or less frequent. I'll show you in the next slide. And management I'll talk about also. So whenever you detect a child, because we are doing headache as a topic, not as an outpatient headache only. Okay, so this is very important. So whenever you have a headache, progressive headache, and you think that this is a secondary headache, and you do a fundoscopy which is undilated, which may or may not be reliable completely. Whenever you do undilated fundoscopy, please switch off lights, make your room dark, then probably you'll have some dilatation of the fundus pupil. Now, the first thing is to confirm with a dilated fundoscopy, request the ophthalmology colleague wherever you are. And also ask them that please do frozen grading of papilledema. I'll not go into the details, but this is basically to differentiate between mild, actually minimal, mild, moderate, marked, and severe, depending upon the features. We will leave this to the fundoscope, this ophthalmologist, although we can discuss here. But this is very important. So confirm by dilated fundoscopy. And next, what is the significance? Depending upon the frozen grading, you can decide about how frequently you have to see. You can refer to this slide subsequently because it's recorded, you can see this. This is very important. And then just for our clinical information here, that there are some radiological features which are suggestive of raised intracranial pressure. And I'll just highlight some of them. So first you see is that flattening of the posterior pole of the globe is one of the radiological features which can be suggestive. It's not pathognomonic. Then you can have prominent of perioptic space. Generally, the radiologists use 6 millimeters as cutoff. If it is wider than that, then they say it's a wide perioptic space. Then vertical tortuosity of the optic nerve in that is another feature. And if you look, I'm not sure whether the pointer will be showing on the screen, but if you see on the lower left panel, so you see empty sella there. And last on the lower right panel is basically, if you look at the transverse venous, this is a venogram. So on the bilateral side, there is a narrowing of the transverse venous sinuses. This is also quite reliable, but it is still suggestive. So these can be used, and radiologists do suggest that, okay, there are features on the MRI which are suggestive of raised intracranial pressure, but gold standard is doing a lumbar puncture to measure CSF opening pressure. So I'll not dwell a lot there. I just wanted to give you an idea. So we had features to put it into chronic progressive. We picked up red flags. We thought it's secondary, and we then did fundoscopy, which gave us information that it is probable papilledema. And then you referred it to ophthalmologists to confirm by dilated fundoscopy. And once they confirm it, we further request them to do further testing, which include visual acuity. We ask them to do Goldman visual field testing, and color vision is also tested. So that part is very, very important, because that will help determine the long-term outcome and the need for any surgical intervention or medical intervention. The scope of discussing medical and surgical management is beyond this presentation, but I can do if somebody wants to. Okay, next case is a 14-year-old girl presented with a history of long-standing infrequent. Infrequent is less than 1 per month headaches with features of migraine without aura for the last few years. So she has a diagnosis of migraine without aura, which are infrequent migraine episodes. This is actually one of our recent cases from here. The Heart Medical Center at Alain, just I think 2 months back. She had a diagnosis of migraine, but she had acne. She saw a dermatologist here, and she was started on Roaccutane, which is retinoids, and this led to worsening of her headaches, both in frequency and severity. She was advised by the dermatologist to discontinue treatment for the time being and seek advice from the neurologist. So I saw her here, and by that time, when I examined her, so she had reported frontally located throbbing headaches, which are typical of migraine. There was no intermittent visual obscuration. I asked these questions. There was no pulsatile tinnitus. There was no diplopia. And there was no worsening of headaches on coughing and bending forward. When I did her fundoscopy here, which was undilated, that seemed to me as unremarkable. However, as she had already stopped her treatment, what I did was, okay, let's first discuss this. What is this headache pattern? So this is a headache pattern, which is a long-standing recurrent pattern, which is a primary headache. But on top of it, there was a progressive worsening. So it was a recurrent headache pattern to start with, but then it became a chronic progressive pattern after institution of Roaccutane, which is one of the drugs which can cause raised intracranial pressure. And this is important for counseling. Okay, so but I asked relevant questions, and the fundoscopy was unremarkable. My feeling was that Roaccutane can cause headaches, which can be non-IIH related, or they can be IIH related. My impression was that as the medication has already been stopped, these are not IIH related headaches. So what I did was I just provided her lifestyle advice, which was 5 factors: adequate hydration, meal regularity, good sleep hygiene, minimal screen time, and engaging in physical activity, and asked her to see me in 4 weeks. So when she came back after 4 weeks, she was almost headache free. And then I asked her, you can go back to the dermatologist and restart if you want to. This is not my advice, because she was quite keen to start this. And then we will see you after 1 month to see how it behaves. Fortunately, after reuse of Roaccutane, after 1 month, when I saw her, she was still headache free. There were no signs of high pressure headache. And actually, although Roaccutane was a confounder, but it had not caused IIH. So this means that you have to put things in context. So she is headache free and restarted on Roaccutane. Case 5, 15-year-old girl presented to pediatric neurology OPD with history of recurrent bitemporal squeezing headaches, starting generally in the afternoon, lasting for the rest of the day at a frequency of 2 episodes per month for the last 10 months. There was no history of nausea, vomiting, phonophobia, or photophobia. She reports scalp soreness. So when she touches her scalp, so it is sore. On examination, there was no high pressure headaches, and there was no papilledema on fundoscopy. And earlier, there were no information available about intermittent visual obscurations, pulse style tinnitus, or diplopia on lateral gaze. So what was this headache pattern? This is actually a recurrent pattern, which we know that is generally a primary headache. Any red flags? We cannot see any red flags here. Is it a primary headache or secondary? Yes, it is a primary headache. Does it need fundoscopy? Although you will do it in the clinical setting, okay, you can do, but imaging is not warranted in this case. And how do you manage? We generally, we know we start with lifestyle, and that's very important. Always start with lifestyle advice. Give advice about analgesia and possibility or risk of medication overuse headaches. So it should not be overly used medications. And generally working at lifestyle factors help alleviate the severity or bring down the numbers also. And that will also, whenever these patients will go to other doctors, if you have already given a lifestyle advice, allowed sufficient period before jumping on to regular prophylaxis, and that will be appreciated and acknowledged. I'm sure that will be. Case number 6, 15-year-old girl with a background of acute lymphoblastic leukemia. This was actually UK. She was treated for acute lymphoblastic leukemia and was in remission for 5 years, and she was under regular oncology surveillance. She had been having headaches initially occurring monthly, now almost on daily basis. And these can hurt her head all over. Some of them could be throbbing, while others could be squeezing in nature. She tends to have to use paracetamol on daily basis. She has failed 3 migraine prophylaxis medications, and recently oncology had done a repeat neuroimaging to see any recurrence of the malignant disease, but that was unremarkable. So, and on there was no high pressure headache features, which is headache worsening on coughing, bending forward, or straining. And there was no papilledema. So imaging had already been, so you have that information with you. So what is the pattern here? So although there are red flags here, malignancy is a red flag itself. Treatment of malignancy itself can lead to immunodeficiency. That can be a red flag here. There is regular use of paracetamol we can see here. We see 2 types of characters here, which is the throbbing character and squeezing character. So it's a mix of everything. And if you see lately, the headaches are occurring almost on daily basis, which were infrequent initially. So this is actually a headache pattern. Risk factors are there, red flags are there, but it's a chronic, non-progressive kind of headache pattern, which is generally seen in chronic daily headaches. If we look at under chronic daily headaches, we have different possible clinical entities like chronic tension type headache, chronic migraine headaches. It can be a medication overuse headaches, and new onset daily persistent headache is also one of the possibilities. And if you see that it is probably a combination of everything. I was very commonly coming across patients who were long-standing headaches, initially infrequent or frequent episodic, then becoming daily headaches, and then having features of both tension type and mix, and then there was a regular use of pain. So it's not uncommon to see all these things there. So chronic daily headaches with components of chronic migraine headaches, chronic tension type headaches, and medication overuse headaches. Do we need to investigate this child? No, she has already had MRI and the things, so just monitor how to manage a lot of good counseling, lifestyle advice, cutting down on pain medication, which can be done in two ways: abrupt stopping it, or gradually coming down and starting a regular or some effective or alternative prophylactic medication. A 7-8-year-old boy presented with the history, a progressively worsening headache, vomiting, lethargy over the last few weeks. There was a previous history of nephrotic syndrome. This is a case we came across, I think, 10 years back in Leicester when I was there. So on examination, he was lethargic. There were high pressure headaches. So in the last few weeks, he developed a progressively worsening headache. There were signs of high pressure headache, and the fundoscopy revealed papilledema. And there was a nephrotic syndrome is a risk factor here. Actually, he had actually developed. Okay, let me first talk about the pattern. Pattern is basically progressively worsening headaches. Red flags are there: short course, progressively worsening headaches. Nephrotic syndrome is a red flag here. High pressure headaches is a red flag here. Is it a primary or secondary? Most likely secondary. And as I told you, fundoscopy was done, and then neuroimaging revealed cerebral venous sinus thrombosis as a complication of nephrotic syndrome, because you can develop coagulopathies in these children. And so just to recognize this, and management, actually, he required surgical intervention. Initially, he had optic nerve fenestration as a short-term measure. Later on, he required actually a VSD also, but sorry, VP shunting also, because his condition was very refractory and he was developing a deterioration of vision. Next, case number 8, I think second last case. 9-year-old boy presented in Children's Hospital with frequently occurring, progressively worsening occipital headaches, which will be aggravated by physical activity, intermittent nausea and vomiting, and he also had episodic imbalance also. Cough impulse was positive, which means when he will cough, his headache will worsen at the occiput. So again, is it acute, recurrent, progressive, or non-progressive? So this was actually a progressive pattern. Any red flags? Short duration is a red flag. Occipital location is a red flag. Worsening aggravation with physical activity is a red flag. And intermittent balance problems is a red flag. And actually, he had fundoscopy, which was unremarkable at the time of examination, but his MRI revealed a Chiari 1 malformation, which is a secondary cause. This is Chiari 1 malformation. If you look at, again, I'm not sure whether my pointer is showing there. If this is the foramen magnum here, and if this vermis is 5 millimeters or more below this, this is called Chiari 1 malformation. Chiari 1 malformation is not always a case for surgical decompression. It depends on the amount of CSF flow on the both sides, and it requires monitoring. Okay, so I just wanted you to familiarize. Last case, allow me 2-3 minutes only. Very interesting case. This was from Leicester also. 14-year-old Polish girl presented to hospital through emergency department with encephalopathic illness. So she was like encephalopathy. She was admitted and underwent an infectious metabolic toxins related and neuroimaging investigations, and everything came back inconclusive. She stayed in the hospital for about 1 week to 10 days and subsequently recovered on its own without any definitive diagnosis. She had a similar presentation 6 months later, and she underwent some more investigations. Again, it was inconclusive and discharged home. After this, she developed 3 episodes a few months apart each of headaches, And these were associated with difficulty speaking, pins and needle sensations on one side, and she had difficulty walking for a few hours, but then she had a complete recovery. So at that point, okay, first let's talk about, although initial two presentations are encephalopathy, you cannot say it is headache, but the subsequent presentation of headache was 3 intermittent headaches. So it is a recurrent headache. Okay, that pattern, so most probably we are looking for a primary. Any red flags? Red flags here are, if we take into consideration initial encephalopathy, that is a red flag. Then difficulty speaking and pins and needle feelings and difficulty walking is a red flag. And I'm sure you must have guessed what it is. Differential diagnosis is quite wide, but what at this stage we thought of some possibility. I'll talk to you about it. So it is primary headache, and neuroimaging initial was normal, but we sent for hemiplegic migraine gene panel, and she turned out to be ATP1A2 gene mutation, and she had familial hemiplegic migraine type 2. And interestingly, after 2 years of initial presentation, when we did her MRI, it showed cerebral atrophy. And if you read about familial hemiplegic migraine, there are three main types, and 3 main genes are associated: CACNA1A, number 2 ATP1A2, and number 3 SCN1A. And very interestingly, again, type 1 in a large number of cases, and type 2 also can present with encephalopathy or comas. Initially, coma can be there. So in a child, those who are working in inpatients, in a child who is presenting with encephalopathic illness, in addition to other differential diagnoses, keep hemiplegic migraine also in your differential familial hemiplegic migraine in the differential diagnosis, and keep monitoring. And this child subsequently developed cerebral atrophy, which is one of the complications. And she was actually, we treated her with flunarizine, and she responded very well as headaches are concerned. Thank you very much, and sorry for my fast speaking. Sorry. Any questions?
Thank you, Dr. Rashid. So I missed you at the beginning because I had a problem with my connection. Thank you for this nice and informative presentation and the clinical scenarios which you have seen. If anyone can have a question.